Hello, I'm Professor Shane Darke of the National Drug and Alcohol Research Centre at the University of New South Wales. Welcome to our series of lectures on drugs and the body. Today we're going to cover a rather amorphous group of drugs that fall under the rubric novel psychoactive substances or new psychoactive substances. Either is acceptable. The difference between novel and new is mysterious, and I personally am not fussed which we use. What do these drugs mean? Well, what they are a group of drugs that have risen to prominence in the early part of the 21st century, since the turn of the century. They really are drugs that, if we were giving this talk in 30 years' time, would probably be collapsed into other categories that are existing categories. What these all just have in common is that they're novel or new in the sense that they've risen to prominence in recent years. I should point out that some of these new psychoactive drugs are really old new psychoactive drugs developed in the middle part of last century. So it just emphasises what we're talking about is changes in behaviour rather than necessarily new substances. What are the major types of novel psychoactives? Well, there's three major groups. There are hundreds of these, but for the purposes of understanding them, think of them as three major groups. The first group are the synthetic cannabinoid receptor agonists, SCRAs. They're a wide group of drugs that include well-known brand names such as Chronic or Spice, typically sold in small packets of 2 or 3 grams. They look like cannabis leaf. They are not cannabis leaf. They are completely unrelated to THC. If people talk about synthetic marijuana or synthetic cannabis, the one thing it is not is synthetic marijuana or synthetic cannabis. They're a completely different group of drugs, and we'll talk about their effects in a minute. The second group, the synthetic stimulants or hallucinogens. Many of them have both stimulant and hallucinogen effects. These include the synthetic cathinones, commonly known as bath salts, phenethylamines, N-bome is the most common one. These have far more higher rates of hallucinogenic effects than the cathinones, which are more typically a stimulant. I say synthetic cathinones because cathinones can be natural in drugs such as cat, which is used widely in Africa. The piperazines, BZP, and the tryptamines, DMT. These are the major ones. The major ones really are probably the synthetic cathinones and drugs such as N-bome. The third category are a group of depressants. Fentanyl analogues being the major concern in many cases. Carfentanil, highly potent analogue of fentanyl. Furanylfentanyl is another example. These are not licensed products. In fact, many of these drugs were never marketed due to concerns about their safety, and they have never been had their safety tested in proper trials. So they're not. What they are produced by in illicit chemistry. The fentanyls are particularly dangerous. They're highly potent and can cause respiratory depression and death in very small doses. Another of the depressants that's widely used is gamma hydroxybutyrate, GHB. This is an example of a really old new drug. It was synthesised in 1960. It's sometimes referred to as liquid ecstasy for reasons that are mysterious, because it has nothing to do with MDMA and it's nothing like MDMA. It's a potent depressant, but it also curiously produces excitation and sexual arousal. Sold and used basically in liquid form, and it's a drug that's been associated with club culture. And finally, amongst the depressants, the designer benzodiazepines. Now, we speak in another lecture of the illicit benzodiazepines. These are, again, drugs that have never been marketed, and they're of unknown toxicity, and in many cases they appear to be more toxic than the illicit ones, and they are not marketed or tested for appropriate dosage, etc. Drugs here, the major ones are atizolam and fludromazolam, but there's a whole range of these drugs. As with the fentanyl analogues, these are analogues of legal drugs that are illicitly designed and produced. Let's have a look at the toxicity of these drugs. There is toxicity associated with all of these types of substances. Synthetic cannabinoid and receptor agonists, particularly interesting in their effects on the cardiovascular system and the central nervous system. I said before, they are not synthetic marijuana. In fact, their range of effects looks remarkably like psychostimulants. They're far more closely related in their effects to drugs such as methamphetamine than they are to cannabis. They have effects on heart rate. They can cause hypertension. They can cause arrhythmias. And there are deaths associated with it. In my own research, and others have also, we have documented deaths of people after having consumed these drugs. They are far higher risk. People do not die of cannabis toxicity. They can and do die of SCRA toxicity. The central nervous system effects, including tense anxiety and agitated delirium, that is, this delirious, person's running around, they're paranoid, they've lost contact with reality, and quite often they cause danger to themselves or others. They can be so agitated that the effects, they're running around and the effects upon their heart can result in cardiac arrest. Hallucinations, paranoia, psychosis and seizures are all toxic effects of these drugs. The second group, the synthetic stimulants and hallucinogens, their effects, acute as you'd expect, are typical to those of the psychostimulants or hallucinogens. So we're going to see the types of cardiovascular effects that I spoke of before. So they can be accelerated heartbeat, arrhythmias, and hypothermia, increased temperature. Now, the depressants all really have very similar effects. The major toxic effect is respiratory depression, and that's the major cause of death. It can result in respiratory arrest, coma. GHB can also induce seizures. GHB as a club drug, I think people who are using this drug, possibly because it's used in the context of clubs, are unaware that it's a dangerous drug. It can and does result in death, and the people are often completely unaware of how much they've used because it's a clear liquid, and commonly put in, for instance, an alcoholic drink. And of course what you have there is the effects of two depressant drugs. The fentanyl analogues and the illicit benzodiazepine, the unregistered benzodiazepines, the major risk again here is respiratory depression. What I would emphasise here is that these are drugs that are typically higher. They're higher in their effects and more potent than the registered drugs to which they mimic. Let's have a look at novel psychoactives in the heart. The two drug classes here of interest are the synthetic cannabinoid receptor agonists and the synthetic stimulants, hallucinogens. Looking first at the SCRAs, their acute effects, hypertension, that is raised blood pressure, this tachycardia, accelerated heartbeat, arrhythmia, an uneven heartbeat, chest pain, and myocardial infarction, that is a heart attack. This is not a profile you see with cannabis. This is a profile that I would present to you if we were speaking today about the psychostimulants. These drugs look and act remarkably like drugs such as methamphetamine and cocaine. That is, they are toxic to the heart. They put stress upon the cardiovascular system, and this can result in arrhythmias and death. The chronic effects, of course, are going to be what you would see, and I think we will see this in the long run if people use these drugs long enough. One of the things about the MPS we don't know yet is their natural history in terms of how long people will use these for. Will they be drugs such as methamphetamine with long use careers, or are they self-limiting? Not enough time's gone by, time of recording in 2022, for us to comment on that. However, chronic effects of SCRAs will look exactly the same as the chronic effects of the psychostimulants, that is hypertensive and ischemic heart disease. Similarly, the synthetic stimulants and hallucinogens, again, the common acute effects are those that you expect to see with such drugs as who are stimulants more generally: arrhythmias, chest pain, hypertension, tachycardia, and accelerated heart rate, and in some cases vasoconstriction, that is narrowing of the vessels. We do see with the cathinones, cathinone-related hyponatremia. What this is a reduction in the concentration of sodium in the body. So the blood concentration of sodium is down. What this has an effect on is it can actually cause an arrhythmia of the heart and possibly death. Now, this has been associated with ecstasy in the past, with MDMA, but we do see it with the cathinones as well. And the regular use of these drugs, we would expect to see the types of chronic effects that I've discussed. That is, I would expect to see hypertensive and ischemic heart disease. I would expect to see enlarged hearts and ventricular hypertrophy, and quite probably coronary artery disease. So looking at those two classes, they look remarkably like the stimulants more broadly. The depressants, in contrast, are not known to have effects upon the heart. Now let's move on to look at the effects of the novel psychoactives on the brain. There are a range of effects that we see, but the major ones here, the SCRAs, the synthetic cannabinoid receptor agonists, is seizure, fitting, and both ischemic and hemorrhagic stroke. That is, they can cause blockage of arteries, and that can be through vasospasm, for example, or vasoconstriction, so the vessel is acutely constricted. This reduces blood flowing to the brain, and parts of the brain are consequently affected. Hemorrhagic strokes, I mentioned before that the SCRAs increase blood pressure, and increases in blood pressure increase the risk of hemorrhagic stroke, that is a bursting of an artery and bleeding into the brain. The synthetic stimulants and hallucinogens, we are seeing the same sorts of effects. That is, you'd expect to see of any of the stimulants an increased risk of seizures, increased risk of both ischemic and hemorrhagic stroke. So these are similar to the SCRAs and to stimulants more broadly. And we see an increased risk of serotonin syndrome. That is an excess of serotonin, and what this can result in severe cases, it can be confusion, muscle rigidity, This can affect respiration, and there can be coma and death in severe cases. The depressants, there are some differences between them. The one that stands out here is GHB. GHB is known, unlike other depressants, to be neurotoxic, as directly toxic to the brain. And it's been shown to be associated with severe memory problems. GHB is a very powerfully reinforcing drug. It has a potent withdrawal syndrome, and it has a high dependence potential. So regular and more frequent use is going to have more obvious effects in neurotoxicity and severe memory problems. All of the drugs, GHB, the fentanyl analogues, the benzodiazepines, all of these cause respiratory depression, and in overdose can cause thus anoxia, that is reduced or in fact ceased oxygenation of the brain, causing diffuse damage. With the various benzodiazepines, as we discussed in a lecture on the hypnosedatives, the abrupt cessation of these drugs, if someone's abusing these drugs, which are generally more highly potent than the registered benzodiazepines, can precipitate seizures and a severe withdrawal syndrome. Now let's move on to look at the liver. The only real drug class here of interest are the synthetic stimulants and the hallucinogens, and in particular the cathinones. The other drugs are not known to be hepatotoxic, that is, they're not known to directly cause damage to the liver, but the cathinones are. They stand out on this. This is a result of the oxidative stress that they place upon the liver, and this can result in cell death. The second thing is the hypothermia. That is, cathinones can increase the body temperature, and this can be at a severe level, which can cause damage to the liver. So of the drugs, of all of the ones we've discussed today, the ones that are concerned with liver pathology are the cathinones. The lungs, just to briefly, really the only drug here of particular interest of the variety of drugs, the SCRAs. Inhalation is associated with diffuse lung damage and pneumonia. I'm not suggesting this will be the result of any use of these drugs. With all of these things, more frequent use is the factor that causes the risk of harm to increase. And of course what we're talking here is a smoking related route of administration, and the sorts of effects that we see across smoking more broadly. Let's have a look at the kidneys. There are a number of issues here that we see the MPS being associated with various forms of damage to the kidney. Firstly, to look at the SCRAs. The SCRAs are associated with acute kidney injury. Why does this occur? This occurs because of the hypothermia that we discussed, and malignant hypothermia that sometimes manifests with these drugs. This results in rhabdomyolysis, that is muscle meltdown, and the release of myoglobin into the blood, which is toxic to the kidneys. This can cause acute kidney injury and indeed acute kidney failure. This is also true of the synthetic hallucinogens and the stimulants for the same reasons. I think in many ways, if we think of the SCRAs, even though they are a separate group, in terms of their effects, these two classes are drugs that cause hypothermia, that can cause rhabdomyolysis, muscle meltdown, and therefore injury, acute kidney injury or failure. And finally, the depressants. And if what we can see with all of these drugs, and particularly with potent forms of these drugs, is again acute kidney injury and possibly failure due to rhabdomyolysis. Now in this particular case, the muscle damage that leads to this is not due to hypothermia, it's not due to high temperatures. It's due to someone being unconscious and laying on a limb for a prolonged period of time, causing cessation of blood to the muscle and muscle breakdown. But the end result is the same, but the mechanism is that cause this damage is distinct. All right, let's have a look now at mental health. Firstly, the SCRAs, they can cause agitation, hallucinations, panic attacks, and that agitation can be extreme, like an agitated delirium. The potency of these drugs, if you compare it to cannabis, which people take to get similar effects, even though I think I've emphasised quite a number of times that these are very distinct, pound for pound is far greater. And the effects, for instance, in an intense agitation and a delirium can be intense and dangerous to the individual. They may also exacerbate psychotic episodes. And bear in mind, if we're talking about drugs that pound for pound in potency are 80 times greater than cannabis, for which they're being used to substitute, even though people are unwittingly substituting a stimulant, you see that the risk for harm is subsequently greater. The cathinones can cause, again, a similar range of effects: anxiety, agitated delirium, psychotic symptoms. The excited or hallucinatory delirium, that's particularly we see with drugs like Mbone. This delirium can result in death. People can do things they would not otherwise do. They may be delirious, think they can fly, jump off cliffs, etc. With the depressants, GHB, the withdrawal syndrome here is intense, and it's something that needs to be medically managed. It can be associated with anxiety, restlessness, hallucinations. It's a substantial withdrawal syndrome, and in terms of its psychiatric manifestations, person can be in a quasi-psychotic state that needs to be medically managed. Finally, let's just examine some of the other conditions that we see associated with MPS that may cause harm. The synthetic cannabinoid receptor agonists, I said previously their effects are more stronger pound for pound compared to cannabis, sometimes, for instance, 80-fold. While cannabis affects coordination, the effects of the SCRAs are many times that of THC. So the effects, the risk for falls, accidents, traumatic injury is subsequently greater. The agitated delirium syndrome, which is associated with these drugs, which looks remarkably like that we see with drugs such as methamphetamine, presents a high risk of traumatic injury to the person. Highly agitated people doing dangerous things, and quite often paranoid and aggressive. The synthetic stimulants and hallucinogens, again, in high dosages, we see with some people this agitated delirium syndrome. Again, both of these drugs, therefore, the synthetic stimulants and the SCRAs, what we're seeing here are the stimulant type effects that can cause danger to the individual. Let's look at the depressants. With all of the depressants, there's risk of injury because people are discoordinated, and people using these drugs or abusing these drugs should most certainly not be operating machinery or driving, but there is an increased risk of falls, etc. And keep in mind that the fentanyl and the fentanyl analogues and the benzodiazepine analogues are typically more potent than the registered drugs. GHB, there is an increased risk, of course, through discoordination, etc. But there's the paranoia, the hallucinations that can be seen, and an agitated delirium that is quite unusual, and it's I can't get it across enough more strongly that this is a potent drug that is associated with a wide range of harms. Fentanyl, like all opioids, can cause constipation, and it's associated with poor dental health. It reduces salivation, like all opioids, can increase bacteria in the mouth and increase risk of dental caries. And as I've said, all of these drugs are associated with discoordination, and in many cases also with disinhibition, which can result in increased risk of traumatic injury. Thank you for viewing this lecture on the novel psychoactive substances, a wide range of drugs and a complex series of effects upon the body. All of the issues that we discussed today are presented in our book, The Pocket Guide to Drugs and Health. This is a page-at-a-glance resource that presents information on the effects of all of the major drug classes on each of the major body systems upon the brain and mental health.